So the polyps can be divided into 4 different kinds. Adenomatous polyps, inflammatory polyps, hematomatous polyps, and metaplastic polyps. So adenomatous polyps and hematomatous polyps have the trend to become cancerogenesis. For the inflammatory polyps, usually they have no chance to become the cancer. Metaplastic, few of them will become cancer. And for the gross appearance, there are 2 types. One is pedunculated, another is sessile. What is pedunculated? This is sessile, and this is how to pronounce this one? Sorry, pedunculated. Okay, pedunculated polyps. So they have this stalk. So laboratory examinations, I think I mentioned it before, but these 2 mentioned here. One is for fecal occult blood test. So every patient in our department will receive this test, fecal occult blood test. And another is tumor marker. CEA is most commonly in this colonic cancer, so carcinoembryonic antigen. And in United States, they use FOBT test plus sigmoid scopy, not flexible, for screening in normal patient, normal people population, not a patient, and they can find some early stage patient, and so this for screening is better for fecal test. Another I think is the same, and the colonoscopy is gold standard. It's the same. So barium edema, the tumor here. So cancer is in secant, and is a polyp here. This what kind of polyp is this one? Yeah, pedunculated. Okay, so. And this is carcinoma. So because it's causes the constriction, it's called apical appearance, apical. So the polyps, for historical appearance, adenopolyps, because with the Formosan classification, there's 4. And for adenomatous polyps, it can be divided into three different types. Tubular adenoma, 65%, villous adenoma, 5 to 10%, and the tubulovillous adenoma. So the villous adenoma have a more intensity for the cancerogenesis. So the incidence of invasive carcinoma being found in a polyp is depend on what is the size. Is the polyp size more than 3 centimeters? They have the 50% incidence for carcinoma. And the histological types, the villous adenoma, more chance to become carcinoma. But tubular also have some chance. Have relatively less. Okay, so next. So this is scorpion views, sessile, pedunculated, and this carcinoma here. Okay. So how to treatment the polyps? Mostly we do snare technique through endoscopic. If the with on a stalk is pedunculating, it's very easier to just cut it. Yeah, here. This is instrument through the endoscopic. Yeah, this pedunculate, yeah. After you do the snare technique, polypectomy, you should severance annually or half years. But for the sessile lesion, sometimes it's difficult to use snare technique. But for the small one, we can also use snare technique. But for the large sessile lesion, usually we should segmental colectomy to cut it to remove, either open method or laparoscopic. We also use some method to endoscopic polypectomy, elevate the sessile polyp with injection saline into the submucosa beneath underlying the polyps. So elevated the polyps, then do the endoscopic polypectomy. So some patients will do like this. But if the very big one or large one, and it's difficult to do the endoscopic polypectomy, we can only do surgery.
We don't do it through snare technique.
Some small one. It's a large size. It's very difficult to do. If you do the snare technique, because the wall is very thin, maybe only 3 millimeters in thickness. If you do the snare technique, it's easier to cause the perforation. Then the patient have to transfer emergency operation. So it's a and another concept is what is the polyposis? Usually the polyposis, the polyps number is more than 100. 100. So in clinic, the FAP is much common than PJ syndrome, Pearce-Jacques syndrome. Yeah. So FAP, from the name we can see it's familiar, so it's hereditary disease. Adenomatous, the polyp is adenomatous. Adenomatous. Benign, yes. And it's polyposis. A lot, yes. So from the name, we know a lot of things. It's familiar, adenomatous, and polyposis. And there's 3 subtypes. Not all the FAP is the same. Attenuated FAP, a less number of polyps, late onset. Tokat syndrome is called with brain tumor, central nervous system tumor. FAP patient with central nervous system tumor.
They have both of them.
Yeah,
They have these tumors.
Yes. Also Gardner's syndrome, osteomas.
They
Wow.
have some relation?
Yes.
What relation? Brain tumor?
It happened at the
At the same time?
no, yeah, they have FAP. Then later or at the same time they found the osteomas. So it's called Gardner syndrome. But it's not so common, this disease, because FAP you cannot see a lot of patients. Then the Gardner disease syndrome or Tokat syndrome, you will just know it. So the FAP may be complicated with another part of organs, brain, osteomas, sometimes pancreas osteomas. So I will explain later.
Should we count the polyps? We count them? Or we...
It's sometimes so difficult to count. If it's polyps more than 1,000, you can't? No.
Then how do we say it's 100 and it's about...
Just estimate. it's not so accurate number.
So if it's 99,
Estimated.
if it is 99,
Oh, that is okay. 99, I think 100 is okay. I think this is the same. What about one polyps? So big difference? No.
so you have to kind of.
So the FAP is prototypical hereditary polyposis syndrome, APC gene mutation. APC gene mutation. And it can cause colorectal cancer 100%. 100%. Most people, if they reach the age of 40, most people will happen colorectal cancer. So this is why we should treat FAP at the very beginning of the disease. So other findings include duodenal adenomas, founding gland hyperplasia, mandibular ostomas, mandibular and supernumerous teeth, more teeth than normal people. So how to treat FAP? Because we know.
We cannot do total.
Yes, we should do the total. Yes, you're right. You're right. Yes.
What about the duodenal? What about the small bone?
The duodenal, the rate is very low. The most for the cancer drainage, the most part is in colorectal. Yes. So this is why we should give the patient a total colectomy with ileal porch and stenosis. You are right. Yes. Thank you. Okay. So this is the same procedure like which
CD is UC.
UC, not CD. Yes, UC. But there's some difference. The punctitis. Yes, punctitis. The inflammation rate is much lower in patients with FAP. Because this is not inflammatory disease. It's polyposis. So the punctitis is much lower in patients in FAP. This is different for the complications. Okay. So this is the most commonly recommended operations. Also some patient with elder one or the general condition not so good, the patient remove all the colorectal ostomy. Permanent ileostomy is also the choice. And sometimes we use continent ileostomy to control the ileostomy. But in our department, we never do this. Some surgeons in other countries, they do the continent to control the fecal movement for this ostomy. Okay, so this is the same method.
How they survive? You remove everything. You give them IV then?
No IV.
If you remove the whole.
The nutrition, mostly the nutrition was absorbed in which part? Small intestine. So we just take.
If in the case if you remove also the small intestine.
No small intestine.
If there are polyps in the small
No.
intestine.
The polyps mostly happen in the colorectal, not in small intestine. Small intestine, they seldom have these polyps. So, how do you calculate the number of these polyps? Hey, can you calculate?
That's why I asked you.
Yeah, so just estimate it.
Maybe we divide it in
More than 200.
area.
One area, oh, maybe this more than 10. So,
So then, yeah.
that's why-
more than 100.
More than 200.
200, yes. So, polyps, yes. So this patient receives a total proctocolectomy, and you can see so many polyps. So FAP, from the name of FAP, familiar hereditary disease, adenomatous polyp, and polyposis. So easy to understand, I think.
Very
Yeah. Okay. So I have explained that. Okay, this is just go through it. For the Gardner syndrome, they also have some congenital hypertrophy of the retinal pigmented epithelium. So we should ask the also what department for eye?
Ophthalmology.
Yes, for eyes doctor to explain to examine this retina. Maybe we can find the retinal pigmented epithelium. And another polyposis disease, PJ, Pearce-Jaggers syndrome, and it's hyperpigmentation of the buccal mucosa, lips, and digitus. So this picture I take from the internet. So this is the hyperpigmentation of the lips, also the fingers. So the numbers, this polyps is hematomatous polyps, not adenomatous polyps. Small number of hematomatous polyps throughout the GI tract, but mostly in small intestine. So how we know small intestine polyps? Do we have some method to examine small intestine? Which kind of endoscopy? Small intestine endoscopy. Yes, we have. We have small intestine endoscopy, but
Fluoroscopy. We can also do fluoroscopy.
We can follow through
capsular endoscopy. Only like medicine, capsular.
The new method.
You yeah, we have this one. Yeah, sure. Yeah, we have 7 years ago we have this one. It's very small capsular. Just take it, and 1 or 2 days from your feces, a lot of pictures of your small intestine. This is atraumatic. It's atraumatic. But we have a small intestine. Okay. Any question?
What are the indications for surgery?
surgery.
Indications.
If the patient diagnosed FAP, absolutely operation. 100% incidence to get cancer. The most important part of epidemiology in the US is second leading cause of cancer deaths. And the 5-year survival, 60. So it's quite good, I think, for colorectal cancer. Red area,
United States, you mean?
yeah, United States. In China, it's third or fourth, different part. In Shanghai, maybe the second. But in the rural area, maybe 4. So the whole country maybe the third position. So the industrialized nations have the greatest risk, the red area. So this is pathogenesis from adenoma to carcinoma sequence. During this sequence, a lot of genes were mutated. Now you can see detail in your textbook. I don't explain detail here. And the pathologist is mostly epithelium tumor. It's epithelium tumor. Okay. So nowadays, the colorectal cancer, 3 different ways. Mostly we found is sporadical, 80%. And 20% is hereditary.
They are not the same, familial?
Not the same. The manifestation, treatment, outcome, the same. But the pathogenesis is not the same. For the hereditary FAP, it will happen to the colorectal cancer, HNPCC, juvenile polyposis also has a PGA. So have the hereditary history. So I will explain in detail later for what is hereditary, what is sporadical, and what is familiar.
So you have mentioned FAP and hereditary, so that is familiar then?
Yeah. This is not familiar. But in the clinic, we never mention this, just colorectal cancer. Transverse colon cancer, sigmoid colon cancer, never mention, oh, it's familiar, oh, it's hereditary. But we should know, even the same cancer is different person, different patient, with a different way to get the cancer, different way. So we know how. So we should know this hereditary, 20%. Yeah, most is sporadic. Okay, so what is hereditary form? It characterized by familial history. Young age at onset. So most people have colorectal cancer of this hereditary form less than 50. But for the sporadical one, usually more than 50, older one. And the presence of other specific tumors and defects have a specific genetic mutations. We know FAP, which kind of gene mutation? APC gene mutation. And this kind of mutation is present in all cells of affected individuals, include tumor cells, your normal cells, in all cells of all infected individuals. So this is familiar form. FAP we have explained before, and when is HNPCC? What is HNPCC? Hereditary non-polyposis colorectal cancer, non-polyposis. So it's a mutation in DNA mismatch repair genes. And its clinical criteria, this will just go through it with some criteria. So we use modified Amsterdam criteria. This is Amsterdam criteria. You can find it in your textbook, so just go through it. And for the sporadical colorectal cancer, absence of family history. Older population, usually more than 60 years old. And the lesion is isolated lesion. Genetic mutations in tumor itself. So do you got the difference? What is sporadical and one hereditary? Yeah, okay. So in clinic, we never do like this, just the cancer, okay, the same. The genetic of colorectal cancer initiation and progression proceed along is a very similar pathway in both hereditary and the sporadical forms of disease. So the initiation and the progression is the same. So what's the familiar colorectal cancer? This concept is relatively new. Before this lecture, I don't know this kind of conceptions. So it depends on the lifetime risk. The risk of cancer increase as the number of familiar members with colorectal cancer rises. So this is called familial colorectal cancer. So we have no the rate of cancer risk rate yet. Only know this we have the familial colorectal cancer. Okay, this is a new concept. So for histologists, mostly adenocarcinoma. And the second is mucinous adenocarcinoma. If more mucinous is a lesion the more aggressive, the more worse for the patient, like the lifetime for the survival. And the poor prognosis is undifferentiated carcinoma, single ring cell adenoma. In stomach carcinoma, we also have the single ring, but in this correct also signet ring cell adenoma, poor prognosis. I have several patients after they receive the operation, only 1 year, or have the recurrence, metastasis, then die. A very poor prognosis for this undifferentiated carcinomas. So others, we have lymphomas, also squamous cell carcinoma. So most of these colorectal cancer, which kind of cell carcinoma? Epithelial. But some squamous cell carcinoma can also find, especially near the endocanal, because endocanal is the epithelium and the squamous cell mix in the junction area. So maybe we can find some squamous cell carcinoma. And it's very important to do the staging. For TNM staging, we have 3 different. T means tumor, lymph node, metastasis. It's very so complicated, but for our specialists, we should remember everything in our mind. It's very important. Before operation or after operation, you should know the TNM staging. Because you should choose the best operation or best way to do the chemotherapy or radiotherapy is depend on the staging. But for your student, I think you should know what is the meaning of TNM. So TX cannot be assessed. T1, no evidence of primary tumor. T1, submucosa. T2, invaded muscularity properties. T3, goes through the muscularity properties into the subselosa. T4, invades as organs or goes through the selosa, outside the selosa. So this is Tn. So N1. So after we do the operation, at least 15 lymph nodes should be tested. And in 15 lymph nodes, if 1, 2, 3 lymph node was found there's tumor inside, it's called N1, N2. More than 3, so 4, 5, 6, N2. M0, M1, so if you have distant metastasis, it's M1. And there's another staging system. It's called Dukas classification. Dukas. So this is typical Dukas staging, only stage A, B, C. Not to mention the distant metastasis. So later on, modified Dukas classification or modified Estrella-Kohler classification, and the D, distant metastasis. So the most popular area for metastasis for colorectal cancer is liver. Yes, because we know the venous drainage or the lymphatic drainage, mostly for the venous drainage from SNV, hot vein, sent to the liver.
Duke's classification is limited to gastro and the GI system?
Yes.
It's only limited to the system?
Yeah. So nowadays, in our department, we use mostly TNM staging. But in some literature, in some countries, they like to use this one. So we should know there are 2 different ways to. So second part for distant metastasis is lung, and someone okay. And which is the Y prefix, and what is the R prefix? Y prefix practice is to be used for these cancers that are classified after pre-treatment. Because when the patient